Good evening, everyone, and thank you for joining us tonight for Illinois Bone and Joint Institute's 26th virtual YMCA Education Series program with the North Suburban YMCA. My name is Karen Brownlee, and I'm a personal trainer and the adult program coordinator at the NSYMCA in Northbrook, Illinois. We are recording this evening's presentation so that you will be able to revisit it again. Please feel free to tell your family and friends about it so that they too can view it on either the IBJI or NSYMCA websites. Dr. Paul Goodman will be hosting tonight's program entitled All About Bunions. What are bunions? Who suffers from bunions? How common are they? How do you know if your pain is caused by bunions? And what can you do about your bunions? According to WebMD, about 10 to 25% of people have bunions, and the Cleveland Clinic estimates that up to 1 in 3 Americans have bunions. Tonight, Dr. Goodman will talk about the causes, symptoms, and treatment options for bunions. Paul Goodman, Doctor of Podiatric Medicine, Fellow of the American College of Foot and Ankle Surgeons, and Fellow in the American Professional Wound Care Association, is an Illinois Bone and Joint Institute foot and ankle surgeon. He is one of only a limited number of foot and ankle surgeons who is board certified in reconstructive rear foot and ankle surgery. His specialty areas include reconstructive foot and ankle surgery, arthritis, trauma, deformity correction, arthroscopic surgery, total ankle joint replacements, and of course, bunions. Dr. Goodman is a nationally recognized lecturer and educator for many topics in foot and ankle surgery. He completed his surgical training at Kern Hospital for Foot and Ankle Surgery, a residency program in Detroit, Michigan, which was the first formal training program for foot and ankle surgery in the world. The graduates from this program are pioneers for foot and ankle training, and Dr. Goodman has maintained his connection with the program by lecturing at conferences sponsored by the Civic Kern Hospital Residency Alumni Association. Dr. Goodman was a partner at the Foot and Ankle Treatment Center in Glenview from 2003 until 2021, when he joined Illinois Bone and Joint Institute. Fun fact for us locals, Dr. Goodman is a native of Northbrook and attended Glenbrook North High School. Despite the fact that his father is a physician and there are numerous doctors in the family, initially, he wasn't interested in a career in medicine. However, after graduating college and working a few jobs, he realized that he had a calling, and that calling was to be a doctor. In fact, he has said, "It's just kind of finds you, I think. At the end of the day, everybody has to do what they love, and as long as you love it, the rewards come." He says that he really finds that helping people is the reward of the job. Dr. Goodman is now married with 3 children and enjoys sports of all kinds. He has worked as the team physician with Detroit's Junior B Hockey League and has consulted for other athletic organizations. In his free time, he likes to play hockey and coach youth ice hockey. Thank you again for joining us this evening, and thank you, Dr. Paul Goodman, for your time and effort in putting together this program to help us understand all about bunions. Now, Dr. Goodman, please take it from here.
All right, so let's get started. Thanks for that great introduction. And I do want to point out that not only am I from Northbrook, but I learned how to swim at that YMCA, so it holds a special place in my heart. So we're going to talk about bunions today, and the first question that always comes to mind is, where did this bump come from? And I hear this all the time. People come in and they say, "I have a bump on my foot." And I try and tell them, well, there really isn't a bump there. And then they look at me like I'm crazy. So I really want to point out what causes a bunion first. And the important part is to understand the anatomy of a bunion. We have 5 metatarsal bones, and these metatarsal bones are actually numbered, and they're numbered 1 through 5, surprisingly, starting by the big toe and moving towards the little toe. And what we're talking about is often referred to as the first metatarsal. And that first metatarsal, it starts to move, and it moves away from the other metatarsals. And this movement causes the toe to kind of twist and lean towards the other toes. And that's what we call a bunion, or often referred to medically as hallux abducto valgus. We say, well, how do we get that fancy name, hallux abducto valgus? Well, most of the time, these are hereditary. In fact, if you look at the internet and you do a Google search on what causes bunions, hereditary comes up almost every time. But what do we mean by hereditary? Because somebody will say, well, my mom didn't have them, my dad didn't have them, why do I have it? What you actually inherit is laxity or hypermobility of a joint. And that hypermobility allows the structures to move into a position that creates the bunion. This can be due to the underlying structure of somebody's foot, let's say a short bone or a long bone, or maybe they have some form of rheumatism in the family. But these are the reasons that people get bunions. And unfortunately, there's nothing that stops your genes. So when people say, well, is there anything I can do to prevent this from getting worse? The answer is not really. You're just going to have to wait it out and hope for the best. It doesn't mean that we can't treat it, but there's nothing that puts them back, so to speak, or stops them from forming. We talk about that term hallux, abducto, valgus. Well, where does that come from? It comes from the three main planes in our body. And when we say planes, we can divide the body into really three different sections. If we look up and down from front to back, the red line on this slide here to the left, you'll see that that's what we call the sagittal plane. If you look at the blue lines going up and down, cutting us from front to back, that's what we would call the coronal plane. And then there's the green line that is the transverse plane, and that's from top to bottom. And if you look at these, the bunion, when you look at these three planes of the foot, the big toe or the hallux abducts, moves in the transverse plane, and rotates in the frontal plane. So that's where we get the term hallux abducto valgus. And often the third part to this, which is why we call it a triplane or all three planes deformity, is because it also elevates a little bit. And that's what gives us that presentation of that bump. The bump is because the bone moves sideways, up, and twists. And then it looks like we have a bump jetting out the side of our foot. But really, that's a dislocated joint. Now, when we look at an X-ray of the anatomy, we can see the 5 metatarsals. And I want to point out these two little circles. And I don't know if you guys can see the pointer on my computer, but these two little circles at the first metatarsal, these are called sesamoid bones. And these are two views of the same foot. If you look on this one, the picture to the right, you can see that one of the sesamoids looks like it kind of sticks out the side. Now, it isn't really sticking out the side. We're just changing the X-ray angle so that we can see something kind of poking out there. And I get this question all the time when people look at their X-rays. What are these two little circles that are sticking out? Is that a problem? It's not a problem. They're normal, but they should be tucked underneath the bone like this. When that bone is twisting, again in that frontal plane, when that bone twists and moves apart, the bones will look like they stick out the side, and that can be one of the ways we can see a bunion. So if we look here, here's a picture of a bunion, and we see that the first metatarsal, this one over here, is drifting away from the middle of the foot in the transverse plane. The toe starts to rotate, and you can see that rotation with the sesamoid bone sticking out over here. And so when we talk about correcting these bunions, we want to correct all three things. If we correct in one or two of these dimensions, we sometimes can leave problems. Now, not always, but sometimes. So we're going to talk about the different ways to treat a bunion. As I alluded to before, the only thing that corrects the problem is going to be surgery. But that's not the only way to treat a bunion. There are a lot of ways to control the symptoms. Some of these symptoms usually come from the things like shoes rubbing against our feet. So how do we do that? We get wide enough shoes. But if you get shoes that are so wide that they can fit a large bunion in the toe box, our heel usually pops out of the shoe. We say, well, my foot's wide here, but narrow here. How do I make it fit? And that's where orthotics can really play a role. A good fitting orthotic can help fill the gap of the shoe where it wasn't fitting properly and create a better fit for the shoes and more comfort. But orthotics will not get rid of a bunion. I always tell people it's kind of like wearing eyeglasses. They can fix what you see, but they don't make your eyes better. And that's the important part to remember about an orthotic. It's not going to correct your bunion, but it's going to make it feel better. Other things that can work are anti-inflammatory drugs. These anti-inflammatories come multiple ways nowadays. You can get the infamous cortisone shot. Some people will take anti-inflammatory oral medications such as Advil and Aleve and things like that. And there's also topical medicines. Some of these topical medicines are even available over the counter now. Aleve comes in an over-the-counter topical, and so does a medicine called Voltaren gel. And these are medicines that we use a fair amount of time with good relief because the bunion is so close to the skin that topicals can make have a good effect on this. Now, just because we're treating it conservatively doesn't always mean that it works. So what do you do if it does fail? Well, when conservative care fails, surgery starts to become an option. And I always tell people, when you're thinking about surgery, there's 3 questions that you really have to ask yourself. And surgery, incidentally, should always be done for pain, not because you don't like the way it looks. And we'll talk about that a little bit later. But when somebody has pain, the 3 questions I tell them to ask themselves is, does this pain interfere with my daily activities? Meaning, I can't do certain things because my foot hurts. Or does it prevent me from trying to do things? For example, I love shoes and I wish I could wear these cute shoes, but I can't because my bunion's gonna hurt. Or I wish I could go skiing, but I can't go skiing because my bunion's gonna hurt. And finally, is the deformity leading to other things that hurt? The most common example would be a hammer toe. People will get hammer toes, usually of the 2nd digit, and the toe may become painful, not the bunion. It's very difficult to correct a 2nd toe hammer toe and leave a bunion because the bunion is usually the driving cause, and the hammer toe does not get corrected as well when you leave the bunion there. So if you answer yes to one or more of these questions, it's time to start to consider bunion surgery. Well, why don't we just go to surgery right away? If it's the only thing that can fix it, why not just have surgery? Well, surgery is not without its complications. So it's good to have a healthy fear of wanting surgery. Bunions, everybody knows somebody that's had them come back or that had pain after their bunion surgery. Or the infamous varus, which is when we overcorrect it, and instead of the toe being in valgus, the bunion goes the opposite way and the toe pokes out towards the shoe. And then there's the things that can always go wrong. The bone might not heal right. Somebody could get an infection and stiffness in the joint. And the other thing that scares people out of surgery is, how long is it going to take? You don't want to be off your foot. And any bone takes a minimum of 6 to 8 weeks to heal. So if you're talking about this recovery time and these complications, we want to minimize those potential complications and have the healthiest surgery that we can with the least amount of complications. Why do people get complications? Well, sometimes it's dependent on the procedure. There's a lot of procedures that we can do for bunions. And if we pick the wrong procedure, sometimes that in itself can lead to complications. We call these procedures cheater procedures. We've all seen commercials that promise to get you back on your feet in a day, no incisions, you name it, it's out there. And the problem is that that just isn't the way bunion surgery should be done. You look at the deformity and say, well, if I'm going to do something quick, I'm going to just shave down the bone and cosmetically make it look better. What's it going to look like in a year or 2? So yeah, those procedures might work temporarily, and for some minor bunions, you can get away with it. But the reality of it is that you have to be very careful and choose these procedures with the right patient in mind, and know that there's not really a perfect way of doing bunion surgery. With each procedure comes its own risks and rewards, and we're going to look at that. These are all, in 5 minutes, I thought of all the different bunion procedures that I've done in the last even just 10 years. And this is a list of all the different types of bunion procedures. Some of these you may have heard of, the chevrons, the scarves, because they're a little bit more common. And more common, the lapidus, which is, there's getting a lot of press on that procedure. And we'll talk more about that in a little bit too. But these are all different procedures. And if you pick the wrong procedure for the degree of bunion, you're going to have problems. Now, all surgeries are done usually with an IV sedation. These are outpatient surgeries. They take roughly an hour. Insurance does cover them for the right instance, and that right instance is usually pain. They're not going to cover it because you say, I just don't like the way my foot looks. If you're not having pain, don't have surgery. And post-operatively, this is changing, but it used to be that we would put people in a boot or a cast or a surgical shoe sometimes, and we would keep you off of the bunion. So you could walk around on your heel, but not really on your foot fully for 6 to 8 weeks. That's kind of a long time to be off of your foot. And if it's the right foot, you got to be careful about driving, because you go to hit the brakes and you're in a lot of pain. You might pull your foot off that brake and suddenly you're in the car seat in front of you. So we want to make sure that when we start to release you to activities, not only is it comfortable for you to walk around, but it's safe. Now, in selecting surgeries, historically we looked at the severity of the bunion. A mild bunion, you could do something closer to the toe. And as the bunion became more severe, we would move further back in that metatarsal towards what we call the base or the arch of the foot. The problem was that as we moved more proximally or more towards the arch of the foot away from the toe, the recovery seemed to be longer. So we looked for different ways of doing bunion surgery. We looked for making the incision smaller to see if that helped. We looked at different ways to cut the bone by different angles and shapes to see if that would help, from crescentics to wedges. And ultimately, certain bunion procedures have become more popular. When we're looking at it, we're still looking for that perfect surgery, the holy grail of bunion surgery. Unfortunately, people stick with what they know. So as you start to do more and more bunion surgery, a lot of surgeons get comfortable with certain procedures and they start to say, well, I'm so good at this one procedure that I can make it work for more bunions than what it was intended. And that's usually when we start to get into trouble. The perfect procedure would correct in all three planes, the twisting, the elevating, and the side to side. It would minimize our recurrence. It would become so strong that we could walk on it in a few days. And when we talk about stiffness, what we're talking about is the big toe being able to bend up and down. Because when we walk and we want to push off that toe, we want that toe to be able to bend up easily. And we don't want it to be painful so that when we push off, it hurts. So does that perfect surgery exist? Well, when we look at that old thought process and we look at the distal ones, which is the ones that we thought were more stable, it turned out that it really isn't true, that people had to stay off of their foot distally as much as they did when we did those more proximal or arch-based procedures. When we look at the IM angle, or how much it pokes out side to side between the two metatarsals, we said, well, that's the only plane that mattered, the transverse plane. Now we're saying, no, it's all three. What about cosmesis? You know, this was a common myth that people cared more about what it looked like. So as long as you made it look good, people weren't going to care what procedure it had. And I would say, I don't know, if my foot still hurt, I'm not going to be too happy just because it looked good. And that goes to the next thing of, do you want form or function? You want it to look good, or do you want that joint realigned properly, those sesamoids back underneath the bone and the bone pushed in all the way? So, you know, just because I can put you in shoes with some of these lesser procedures sooner doesn't always mean that it's the right answer. The most common procedures that we see today are the chevron, the scarf. I put the McBride in here, although that one's kind of fading away. And we'll talk about the McBride is really when we just shave the bump. And the Aiken, and I put this plus minus in here because sometimes when we do some of these different procedures, you need to add a little touch up or cheater procedure to the toe to make it look straight. The important part to remember is that with any procedure we do, what we're always looking for is adequate bone-to-bone contact and compression of wherever we cut that bone so that we can get proper bone healing. If I push a bone too far and there's not enough bone-to-bone contact, the bone doesn't heal very well, and that's where we get into trouble. So in a quick little diagram, the left, you see the bunion deformity. In the middle picture, the blue part is what we would call a chevron, and I'll go more into detail about that, but that's where we just slide that head of the bone, the distal part of the bone, over. That extra screw in the toe is really for what we call that Aiken or that cheater to make the toe straight. And then if you look at the one all the way on the right, that's what we call the lapidus. Now the lapidus bunionectomy, it allows for a ton of correction. The problem with the lapidus historically was it was the one that kept people off of their foot and in a cast the longest. In fact, when I trained back in the dark ages of foot and ankle surgery, when we did a lapidus, when I was a resident, you were in a cast, non-weight bearing, on crutches for 6 to 8 weeks. When we did a chevron, the blue one, people were in a boot and walking on it after week 2 or 3. So who would do a lapidus, even though it was more correction, who wanted to do that? So it was a very difficult conversation to tell somebody, I think you really need this bigger procedure, but you're going to be off your foot for 2 months. So people would do what we call, again, quote unquote, cheater procedure, and they work. People are happy with them. But the question really is, what's our long-term solution? So here's the chevron. This is that distal one. And what we're going to do is, the reason they call it a chevron is because it's a V-shaped cut. And that V-shaped cut's done in the head. And you do it, this is, if you look here, this is a side view of the bone. And what we're going to do is we're going to break your bone in a V and slide it over. And then we add a screw to make it a little bit more stable. That V shape makes it stable in and of itself. The problem is that you only have the thickness of the bone. So as you slide it over, if you have a really large bunion, you can only slide it over to the side far enough where you get to about 50%. Once you're past 50%, you can't move that bone safely anymore, or you're going to run out of real estate. And here's an example of us pushing the bone over. And this is a chevron with an Aiken. The Aiken's the break in the toe to make the toe really straight. And the chevron is us breaking that bone in the V shape here, sliding it over and putting a screw in. Nowadays, I would probably make this a little bit longer and try and put 2 screws in. But these patients are satisfied. They like it. It's a quicker recovery to what we used to do with the lapidus. And the toe is straight, the joint's aligned, and you got a happy patient. Then came minimal incision, and people tried to emulate that chevron, but you can't make really a V cut with a lot of them. So it's just a straight cut across. You rotate it out. And in this case, this actually wasn't one of my cases. This is one of my ex-residents who sent me this, trying to convince me to do these surgeries. And I'm really not a fan of minimal incision surgery, partly because there are variations in people's anatomy. So I never know if I'm going to cut something that I shouldn't in a small incision, especially when you're putting a saw blade in there. But more importantly, if you look at the picture on the right, you don't see a lot of bone-to-bone contact. The hardware companies that sell these devices will tell you, oh, don't worry, it'll all fill in and the screws will do the work for you. Makes me nervous. So I'm not a fan of minimal incision, but if you're looking on the internet at bunion surgery, minimal incision is going to pop up. And it's going to pop up a lot because it's popular and these new kits are expensive and people are using them. So the marketing is going to be there. Then there's the scarf bunionectomy. The scarf bunionectomy is also another very popular bunion. I do a lot of these as well. The scarf is a Z instead of a V-shaped bunion. It happens in the middle of the bone, or what we would call the shaft. And as you make your Z cut, like it shows here on the diagram, you slide the bone over and it allows for 2 screws to be placed. And it's a very stable bunion, easy to walk. In fact, I can walk my scarves usually by 2 weeks and they don't have problems. The issue that you have with the scarf is that if there's a lot of rotation, again, those sesamoids need to be rotated back underneath. And there are little procedures that we can do to pull them over, but you really want them back into the grooves that they sit in. So with this, there's sometimes limitations. Here's an example of one, and you can see that these bones, these sesamoid bones, they're improved, but this guy's still peeking out the side. And that's because I can only get so much rotation out of that. So there are some limitations, but again, the joint's aligned, the bunion's corrected, and you got a happy patient. The lapidus is the one that really looks the best. And it looks the best because we can get the most correction out of the lapidus. And the lapidus is a very popular procedure. The issue that people usually have with the lapidus is, number one, you mention the word fusion and it scares people off. But we're not talking about fusing the big toe. This is a joint in your arch called the tarsometatarsal joint. This is a joint that we really wouldn't perceive a loss of motion. This allows us to rotate the bone, move the bone from side to side, and really make the foot look perfect again. The problem with the lapidus is that two screws across a bone where the cut is straight up and down, people worry about its stability. Now, there have been more recent papers that say that even with two screws, you probably could walk on these sooner than we think. I get nervous about that, so I still keep people off of it when I use two screws. Historically, we would keep this procedure for only really severe bunions because it gives us a really strong lever arm to move the bone over. But nowadays, we're getting a little bit more aggressive. So every one of these procedures can work, but they all have potential limitations. Incomplete correction, lack of bone-to-bone contact. Sometimes we can't address all the planes. And the question is, are these things that lead to joint stiffness and recurrence rates? And maybe that lapidus procedure, if we could find a way to make it more stable and walk on it sooner, maybe we should be doing that for more people instead of just waiting for it to be so bad that we turn to the lapidus. So that's exactly what we've been doing. So nowadays we have new fixation techniques. These new fixation techniques allow us to correct these bunions at their root cause, at the base of the joint where the deformities happen. And we seldom need any cheater procedures with it. It works for any stage. And there are times where we don't even have to open the big toe joint. And that gives us less chance for stiffness. And these things can be walked almost immediately. So I'm going to show you some newer ways of doing this. If you're, again, doing your Google search, you're going to see products out there. Products such as Lapiplasty, Incor, Lapifix, Lapifuse. These are all trademark names of the hardware that people are selling. Any one of the lapidus procedures that people are going to do can be done with these, but they can also be done with existing hardware in the way that these techniques are done. So it really is just a new way of using screws and plates, to put the lapidus together in a more stable way so that we can get you on your foot faster. So here's an example of an old one on the left. That's the one that I showed you. And this is a newer one on the right. And what it is some plating techniques with what we call locking screws. And these have been shown that we can walk you in as fast as 3 to 5 days. So I'm going to just go through some different ones. Here's a different type of example where the screws go into a post. These new equipment is what's really been a game changer. And we can do these lapidus, and you can see there's essentially no bunion anymore. So here's an example. This is the one I showed before. This is what we call 90-degree locking plates. And in these cases, all of these patients, I do still put them in a boot, but these patients were all able to walk after 3 to 5 days of bunion surgery in a boot, in a bandage. There's still icing, you're still elevating, you're still taking care of it, but you're able to walk. So here's just more examples of these bunions. And if you look, you can see how the sesamoids, that rotation of the bone, puts the bones back underneath and lines everything back up. I think this might be the last example. And again, here you can kind of see I know we talked about the elevation, but you can see the foot's a little flatter here. That's the elevation allowing the arch to collapse. Here you can see that it's pushed back down a little bit. So we're able to recreate a little bit of the arch, bring this bone over so you don't have it sticking out the side anymore. And if you look at the sesamoids, they're back underneath. So we're fixing this in all three planes. And again, this is somebody who's able to walk on it in a boot, protected in a boot, after 3 to 5 days. So how has the post-op changed recently? Well, the weight bearing's the big one. I still keep my people in a bandage for 2 weeks, but I do change it after one. By the second week, if there's any stitches, I'll take them out. I still don't like my patients driving until after the first week or until their pain subsides. I'm still going to be taking x-rays every 2 weeks. I usually get people back into their regular shoes at 4 to 6 weeks. We now have some new medicines that help control our pain a lot better with some long-acting blocks and even a new gel that we're using that can keep somebody's foot numb for 3 days. So it gets you past really the bad days after surgery. And by 2 to 3 months, most people are back to sports, running, jogging, wearing high-heeled shoes, whatever you want to do. So the advantages of some of these newer fixation techniques, not necessarily a new procedure, but the fixation has helped us reduce the risk of recurrence. It reduces our risks of stiff joints. It gets us walking sooner. It improves our healing rates. We do end up with excellent cosmetic results, even though that's not the aim of what we're trying to do. It's correcting in all three planes. We can return to all of our activities, and it's a lot less pain nowadays. So the question we ask is, have we actually found that perfect procedure? And the answer is, I don't know. We've only been doing these procedures with these new plating techniques for about 3 years, but everything seems to be pointing in the right direction. So I'm pretty happy about where we've come with bunion treatments in the last few years. And I think that as we're getting, more and more comfortable with these new techniques, that you're going to see people really pushing the envelope of what they can fix and how quickly we can get people back to activities. So that's really bunion surgery in a nutshell and bunion treatment. I'm going to open it up to questions.
All right, well, and you answered most of the questions, but I'm going to read them anyway so that you can confirm or maybe give us a little bit more information. So the first question that came in says, when a bunion begins to form, is there anything that can be done to prevent it from getting worse? And your answer was no, but it sounds like maybe doing surgery sooner.
So, if it's not hurting, I still wouldn't rush to surgery. But unfortunately, no. I mean, there's always that thought of somebody putting a strap on it and splints, and if I wear the right shoes and I don't wear heels. And the reality of it is that you don't have to beat yourself up for the things that you're doing. It wasn't caused by bad shoes, and it's not going to go away with good shoes. It's genetic. The shoes might make it hurt more, but they're certainly not what's causing your problem, and they're certainly not going to correct it.
So people with hypermobile joints are the people who end up with bunions, right? That's what you said. Is that right?
Well, there's a laxity, so it's not always hypermobility, but there's definitely a laxity, so that allows the foot to displace, that metatarsal to swing away.
So people who do have hypermobile joints, like I think of gymnasts who tend to
Sure.
have hypermobility. Are those the type of people with the hypermobility who too end up with bunions?
We definitely see more bunions in people who have hypermobility, but if you have a true hypermobility, sometimes even the procedures that we talked about just now aren't always enough to correct it. And sometimes you actually have to fuse the big toe joint and stop it from moving altogether, because a true hypermobility syndrome, even if you align that metatarsal bone, the toe might still drift over on you. So you have to be
over time because you're hypermobile.
Right.
Got it. Okay. So that's why people's bunions recur, is because they've got a hypermobility in there. So once it's corrected, it still may.
Unless, there are times where that is the case. And even if it's corrected perfectly, they may get another bunion. But there's also times where we just pick the wrong procedure. And that happens. It's happened to me. It's happened to every surgeon out there that does bunion surgery, where we think this is the stage you're at, so let's do this. Or even worse, we sometimes let patients convince us that this is the procedure that they want because their friend had it done, and I want the same procedure. And I'm looking at it and going, well, maybe. And then you do it and you say, look, it really wasn't enough. They really needed something different. And that's why I
Yeah,
show all those different procedures, because there's a lot out there. Just because your friend had one doesn't mean this is the right one for you.
that makes complete sense. Okay. So someone asked, will bunion correctors help, or are they a waste of money?
A waste of money.
Yeah,
I'm
that's,
very
I mean,
blunt
that sounds
on
like what you
that.
said,
Yeah,
but I want to make sure I ask all the questions.
yeah.
Are toe separators a good relief as they push the big toe in the opposite direction, for example, back towards the bunion?
And yes, they are. I like toe separators. There's all different kinds that you can get out there. The key is to just find the one that's comfortable for you and that stays in between your toes. They really are a nice symptom relief. However, for everybody that uses a toe separator that likes it, there's somebody else out there that cannot stand the way it pushes on their other toes. So you just got to try it and see, but they're great when they work.
Great. Okay. Here's another question. A podiatrist once told me that if you need bunion surgery, you should have it while you still have cartilage in the joint. If there's no cartilage, the surgery isn't as successful. Is that true?
It is true, but remember that a bunion itself doesn't always cause the cartilage to disappear. Yes, the joint's displaced, and yes, that joint can be prone to arthritis. And as arthritis progresses, bunion surgery becomes less successful. However, that doesn't mean that you do it before it's painful, because there's plenty of people that wait till their 70s, 80s, and you go in there and you look and they still have fine cartilage. So it's not always the bunion that's going to lead to the cartilage destruction. There's other factors that cause that.
Gotcha. Yep, that makes sense. Okay, great. All right. Someone asks, I have Morton's neuroma and bunions. Is that an issue?
Well, it's more painful, that's for sure. You know, the Morton's neuroma is an enlargement of a nerve in the foot. It can be done at the same time as a bunion surgery if you wanted to do surgery for both. Where it really becomes an issue is that Morton's neuroma becomes painful as it gets squeezed in a shoe. And as you have a bunion, if that bunion's squeezing in the shoe more, the neuroma is more painful.
Got it.
So, you know, it is an issue. Does it mean that it has to be corrected? No, you just got to find the right shoe gear and hope that you can be comfortable. And if you can't, then you fix it.
Okay, great. Thank you. Okay, another question. Is the old Lapidus surgery a long-term solution, or could the bunion come back? I had surgery 26 years ago. Could you potentially perform the new Lapidus surgery on that foot again?
So a Lapidus is a Lapidus, whether it's with the new hardware or not. A Lapidus is a fantastic procedure that does not allow the metatarsal to drift out again. Now, like we alluded to earlier, if somebody was hypermobile and the toe drifted over without the bump sticking out, that can happen. But that, even if you switch to a different Lapidus technique, it doesn't necessarily mean that that would correct that type of deformity. That type of deformity usually is corrected with first MPJ or the big toe fusion. But that being said, the technique is just the screws. It's, you know, there's really no difference in the rest of the technique. And in my opinion, it's just a fantastic bunion procedure that if your joint is aligned right, 9 out of 10 last forever.
Awesome. Great answer. Thank you. What if you had a sesamoid removed? Can a bunion be fixed?
Yes. In fact, there were some early papers on sesamoid removal that said that if you removed the tibial sesamoid, the one, you have two of them, the one on the, let's say, big toe side versus the little toe side, if you removed those because of pain, that there was an incidence of bunions forming because of that. And people needed bunion surgery afterwards. But the sesamoids have nothing to do with what bunion procedure we do. They just help us look at how much rotation we're getting in the bone. So I use the sesamoids to guide that rotation, but there's other things that you can use. So the sesamoids aren't any problem for having bunion surgery.
Awesome. Thank you. All right, someone says, my bunion hurts only on and off. Should I have surgery?
I would say that those are the people that really need to look at the conservative things to try. Have you put orthotics in your shoes? Have you tried anti-inflammatories? If it's not following, I give it again that 3-question rule. If it's not happening regularly, it's not interfering with anything that you want to do, you're able to wear all the different types of shoes, do your activities, and you're not getting any other deformities, I usually tell people to wait. If you're finding that it is interfering with those things, even if the pain is only when you go skiing, but you love to ski, I would think about fixing them.
Got it. That's very helpful. Thank you. Does being overweight affect development of a bunion?
It really shouldn't affect the development of a bunion. It can play a role in somebody who's got ligament laxity, that the foot will splay out more with more weight. But really, if that bunion's coming, it's coming.
Got it.
And if it isn't, you're not going to get one. So it's not really because of weight. Can weight exacerbate it, make it more painful? Maybe.
Got it. Thank you. Do you perform the Swiss technique? I don't know what
So
that is.
I do know it is. The Swiss technique was really, it's been named a couple different things over the years, but it's really a modified chevron. So the
Okay.
Swiss technique is a chevron with a smaller incision, and the screw gets put in instead of through the incision, through a little poke in the top of the foot, because a lot of the screws nowadays have little holes in the screw, and you put a wire in so that you can see exactly where you want your screw to go,
Mhm.
and then the screws just slides over the wire. So we can make smaller incisions and little pokes, and that's really all that procedure is. And I guess anybody can say that they do it, but I wouldn't really call it that. I would still call it a chevron. And for me, I like to make the incision a little bit bigger so that I see everything. And that way I know exactly where I'm putting my screw.
Yeah, as you had said earlier. Great, good. Okay, thank you. This question is it better to have bunion surgery before you're 60? It sounds like you already said, no, you don't have to do it unless you're in pain, right?
Right. If it's not hurting, don't touch it.
Okay. So if it's painful, so someone says, mine is painful now and I can only wear gym shoes and wear an orthotic. So if that person's looking to wear different shoes, then they might want to consider it.
Yeah,
Oh, I feel like I've learned so much already. All right. Okay.
you're hired.
Um, is there anything that can be done for Taylor's bunion?
So a Taylor's bunion is really the same pathology happening by the little toe. And
Okay.
same types of procedures exist. We can break the bone in chevrons, in scarfs. I don't recommend fusing the joint like a lapidus, but there are procedures where we slide it back over even more towards the base, but we try not to go too close to the base on the 5th metatarsal because there's blood supply issues there. So we
Gotcha.
kind of stay a little bit closer to the toe, but we do a lot of the same procedures, a lot of the same success rates.
And so if someone has the Taylor's bunion, maybe they should come to see you sooner if it's starting to go out because you don't want to do it closer to the foot. You said closer to the
Yeah,
toe, or
I think that there are still a lot of procedures that you can do before you get all the way down there
okay.
that still work. So the
Okay,
fifth,
great.
there's still time.
Okay. And someone asked, what kind of procedure is done when there is little to no cartilage?
Yeah, so there are several procedures. The biggest one is going to be probably the first metatarsal phalangeal joint fusion, where you take the big toe joint and you just fuse it back into position. It sounds terrible because people say, if I can't bend my big toe, what am I going to do? But in reality, the procedure is a fantastic procedure. It locks the toe in what we call a position of function. So
Okay.
it's slightly elevated, slightly turned so that you can walk normal. You can wear most shoes, maybe not a stiletto heel anymore, but most shoes. And you really don't know it's fused unless you're trying to wiggle your toe. And it literally gets people out of pain. Now, there
Okay.
are some other procedures that you can do, especially if you're not a good candidate for a fusion. There are implants that we can put in there. There's even total joint replacements of the big toe joint, believe it or not.
Wow.
So you can do those things. But to me, the fusion's really the tried and true time-tested procedure.
Awesome. Thank you. If you have lymphedema and wear a compression sock and a toe cap, does that create a problem?
It does. It creates problems for wound healing because as the foot swells, the wounds can open back up if you have surgery. So, and even if you don't have surgery, that swelling makes the skin more fragile for rubbing and potential wounds in shoes. So we want to make sure that we control it the best we can. And afterwards, we really want to do a lot of compression wraps. So I wouldn't take somebody out of compression bandaging for much longer. Like usually after 2 weeks, you're wearing a regular sock and you're just in a boot walking. In lymphedema cases, you want to keep it wrapped sometimes up to 6 to 8 weeks.
Got it. Okay. Thank you. That's very helpful. And it looks like we already answered the question of what is the big toe fusion. You just explained that one. Sometimes my bunion tingles when I wear shoes that are too tight. It's a tingly sort of pain, but eventually goes away. Is that enough pain to consider surgery?
So I'm going to answer that a little differently. That pain is really the nerve. You have 4 nerves going to each toe. And the nerve on the big toe side of the big toe, I guess is a way to describe it, is rubbing against the shoe. And it starts to tingle because of the pressure of the shoe pressing against the nerve. And as that pressure continues, the nerve becomes sort of dull. You almost lose feeling from it. That's why the pain goes away. So that nerve is being damaged every time you're doing that.
Yeah.
In those cases, you do worry, how long can you compress a nerve before that nerve doesn't like that damage anymore and doesn't recover so well. So those are the types of things that you got to start thinking about when we talk about secondary structures that can be problems. That's one of those ones that I would think about.
Okay, great. So that's someone who might want to consult with you or their podiatric doctor to help them understand, okay, maybe you do need to consider it. Okay, great, great. Who helps someone find proper orthotics?
So there's a lot of different people that will make orthotics. Podiatrists can make orthotics, physical therapists can make orthotics, even chiropractors nowadays are making orthotics. The reality of it is that it's not as important to have the perfect orthotic as it is to make sure that the orthotic makes the shoe fit better. Because as we said, the orthotic's not going to get rid of your bunion. So as long as you have a good match to the sole of the foot, and I personally don't like orthotics with bunions to go all the way underneath the toes. I like to stop them in kind of at the ball of the foot to give extra space in that area of the foot.
Yep.
But it doesn't mean that my way is the right way. That's just what I like to do. And I think that, any of those kind, even some of the over-the-counter products that do that can work. So, any podiatrist should be able to do an orthotic though.
Okay, but it sounds like that was going to be my next question. Are there over-the-counter orthotics that people can try? And it sounds like yes, there are.
Yeah.
And are those over the?
Go on.
Go ahead.
I was just gonna say I would stick to the 3/4 length ones if you're gonna buy them, because as people start to buy over-the-counter devices, if it's too much volume at the toe box, you're just gonna be jamming your foot into something else that's tight, and you don't want to add to the problem.
Got it. That makes sense. Thank you. And my question to you was going to be: are there over-the-counter orthotics out there that say for bunions on them?
That's a good question. I'm not sure I would believe it if they were.
Okay. Okay. But what you're saying is just buy the ones that aren't that don't fill the whole toe box. Get those 3/4 ones. Okay. Great. Thank you. All right. Is there a correlation between having bunions and having scoliosis?
Not to my knowledge, but it would be an interesting thing to research.
Okay. Okay. If bunion surgery isn't recommended, or if the bunion isn't repaired, how likely is it to fix a hammer toe successfully?
So you can, but it's more difficult. There are several complications that people will get from hammer toe surgery while you leave a bunion. The most notable one is a floating toe. So the toe becomes straight, but it kind of sticks up off the ground.
Mm.
And so some people don't mind that because they're in so much pain from the hammer toe itself that just not having it rub on the top of their shoes, they're happy. But
Got it.
there are things, there's little things that are a problem because as that bunion crowds towards the second toe, that toe wants to get out of the way and it pops back up. And then you got
Okay.
this straight toe that sticks up in the air.
Yeah.
So that's really the biggest complication in leaving the bunion and not correcting when you correct a hammer toe.
Okay. Got it. Got it. Do you lose any length in your big toe after bunion surgery? This person says that they think that after their first bunion surgery, their toe is a bit shorter.
So you can, and again, it depends on what procedures are picked, but a lot of times that Aiken that we talked about, where we break the toe to kind of make the toe look a little straighter, that for sure makes your toe a little bit shorter and a little bit chubbier.
Okay. Okay. Thank you. And someone asks, how do I find a comfortable shoe?
It's a great question.
Yeah.
And I can tell you what I tell my wife, who is always looking for the comfortable and cute shoes, right? And I tell her, you got to go shoe shopping at the end of the day, not early in the day, end of the day when your feet are a little bit achy and a little bit swollen. And you put the shoes on, you got to try on a lot. There's not a brand. People ask me that, what's your favorite brand? I said, it depends on your foot, but you got to find it, try them on, and wear them on the hardest surface you see at the store and walk around on that surface for about 3 to 5 minutes. If you still don't like the way that shoe feels, don't get that shoe. If
Yeah.
you can't believe how good it feels, you got a winner.
Excellent. It's funny. That's the same thing I tell my clients and my students is you don't wear shoes in anymore like you used to back in the 70s. If you don't put them on, if you put them on and they're not comfortable right away, just like you're saying, don't buy it. Okay, good. Good. I'm glad I'm giving good advice too. I can tell them now that Dr. Goodman says the same thing. Okay. Someone says my other toes 2, 3, and 4 itch a lot and sometimes have a tingly feeling. I understand that this could be related to having a bunion. Is that a cause for concern?
So the itching can be from the way that they're crowding. Sometimes when the toes crowd together like that, several factors can happen. Number one, you could be pinching the nerves,
Yep.
but you also could be getting kind of a little athlete's foot even in there. And
Mm,
so, when you start to get toes that are bunched together, they start to become more moist. And as that moisture inside a shoe in a dark, damp place gets exposed to things like the fungus that's in everybody's shoes, we start to get a higher incidence of athlete's foot. So it's something that I would definitely see the doctor and have it checked out.
okay, great. Thank you. All right. If you're able to alleviate pain from shoe choice alone, even though you might want to wear cute shoes that cause the pain sometimes, is there any harm in waiting to put off the surgery? I mean, I've heard you say no. Yeah, put it off.
There's no harm. And
Okay.
that might have been more true in the past where we really didn't want to get to the lapidus because the recovery was so long. But
Yeah.
nowadays, there's no stage of bunion that we can't fix. So wait it out.
Awesome. Awesome. All right. Does repairing a bunion straighten out the other toes?
It can, especially if you catch it. That's one of the things that if you do catch it early enough and you take the pressure back to the big toe and off of the other toes, you might see them correct. But there's usually this point of no return. So if certain deformities get past a certain point, no matter what you do to the bunion, the other toes aren't coming back.
Okay, okay, thank you. And I also want to tell you there in this giant list of questions, there were a bunch of people who said, I don't have any questions, but thank you, Dr. Goodman, for all of the great information. And I want to echo that. I learned so much tonight. I can't thank you enough. This has been really informative. I think everyone feels the same way. And we really appreciate your time. Great, great slides, great presentation, and then a great question and answer session. I thought it was terrific. So thank you, Dr. Goodman. Thank you again, everyone, for joining us tonight. Have a great evening. Thanks for all the wonderful information.
Thank you.